Hi, my name is Alex Thomas. I'm a principal data scientist with Pacific AI. I'm here with my colleague Alin.
Hi, my name is Alin Blidisel. I'm the technical lead at Pacific AI. I'm taking care of the AI infrastructure and the deploy of the healthcare AI applications.
And today we're going to be talking about testing and healthcare AI now in sort of this changing environment. We're going to talk about our platform, our tool, with it has a 60 plus peer-reviewed evaluations. As you see the title, and sort of like why and how every organization who's deploying these healthcare apps needs to be working with this sort of testing framework in mind. So we're going to talk a little about why the evaluation why you need to be considering it. And part of that reason is it needs to be much more specific now. New regulations are coming out, not just in terms of like AI in general, but in terms of testing AI in particular regulated fields, especially healthcare. We're going to talk about a little bit how Pacific AI handles that, how we evaluate things, and what scenarios we've built and used to do this tests. And then towards the end, we're going to show a little bit how the platform works. So the first thing to think about is that in the past, with a lot of applications, people who were deploying things that relied on external model vendors sort of just relied on their tests, their benchmarks to say that their models are doing a good job. Well, in the new regulatory environment, that's not really going to cut it. You're going to need to show that your system works with the LLM and does things responsibly. You can handle not just sort of like the classic scenarios of, jailbreaking or what have you. You need to show that you are doing well on the specific things you're working on. So you need to be healthcare specific. So if you just look for one benchmark, you're going to be missing out on a lot of things. So if you are just measuring how you do on a particular clinical task, so maybe you're looking at something that scans through patient records to build a cohort for a clinical test. That's going to miss a lot of other tasks like the demographic bias and other biases that connect to your system. But if you just check for biases, which is another sort of common thing, people want to worry about that. Well, you're gonna, are you going to be checking for demographic biases? Are you going to check for cognitive biases? These are very different animals. And there's also sort of red team exercises that we do. One is that the one thing to consider is that there are people out there who want to elicit bad responses, perhaps for embarrassment, perhaps to just take advantage of the system, to tease it. And you can test for those, but there's still going to be a lot of other regulatory things that they want to test for. I like making sure that you respond properly when a patient's asking about medication. So it's really a complex field that you have to consider when testing these types of systems. And the 6 things you need in your testing philosophy and your testing setup is you need to be task specific. You need to test the actual thing your system's intending to do. You also do need to be healthcare specific. If you're working in healthcare text is a very different thing than other text. So, for example, if you're working in healthcare, but you want to set up guardrails, well, there's certain topics of conversation that are acceptable in healthcare, but they might get flagged in guardrails based off of the generic data. So you need to work with your data, with your kind of data. You also need to test across a range of things. Making sure that it does these tasks well, that it does accuracy is not sufficient. You need to make sure that if it answers a patient, that it also gives whatever sort of necessary caveats they are. And so if let's say you're depending on just like a simple RAG system to answer patient things, well, these caveats are probably not going to be in whatever documents you retrieve for RAG. So you need to have your system take that into account. Maybe you have it as a boilerplate thing, or maybe you fine tune it to give caveats. But you also need robustness. So if you are doing something that's going to be used by different providers, the language of different providers can be very different. And so that could then potentially lead to different behavior of your system. So you want to make sure that your system is both accurate, that it's complete, that it's robust, and that you check all the other boxes around safety and security and privacy. You also need to make sure these tests are repeatable, because if you just test it once and you make some change to your system, you don't know if you've introduced regressions. You don't know if you've broken some important aspect of it, or if you introduce a problem that you won't see in your current data, but maybe the next provider you sign on, things will break for. So you need to be able to repeat these tests, and they need to be repeatable also in sort of in the scientific sense. So you can compare apples to apples between versions. And this needs to be continuous, and you need to be able to explain these results. So these evaluations, they have to be meaningful. So that is, it cannot just be sort of like a well-known benchmark. You run it and it has nothing to do with what you do in your system, nothing to do with your data. Some of those benchmarks are very useful when comparing LLMs in a generic sense, but they're not really relevant to people who are doing things in healthcare. You also do need to make sure you have covered all your bases. So when you have an LLM system, there's many ways it can be used and possibly abused. And you need to make sure that you are giving as broad a test as possible to what your users may correctly or incorrectly do. And you also need to be able to adapt whatever you're doing in the testing to new situations, to new kinds of data, to new regulations. So you need to have a taxonomy of the different sort of tests and things that you're looking for. So if you think in other sort of realms of testing and security, you have these taxonomies of what you're looking for. Like, oh, am I looking for an error where the user maybe puts in the wrong thing? Or am I looking for bad behavior? Or am I looking for testing for some sort of instability in my system? You have these risk models in mind. You need to do the same thing when you're testing your LLM and the system around it. And again, super stress this. You got a version and you got to repeat the testing and you got to make sure that it stays stable or hopefully, improves over time. So what we've done is we have these 60 plus different test suites that are mostly focused on clinical. There are some generic data sets in there, but they're mostly focused on clinical data. And we've organized these so that when you test your system, you can see where there are problems and where there can be improvements. And we work with a lot with a team from Stanford. We work with MedHelm. We use Lang Test, which is a tool John Snow Labs built that allows us to really do a good job of testing robustness by creating variants of documents and of inputs across different dimensions. We also build our own data sets using our in-house experts. Let's talk a little bit more about these data sets. So I'm going to walk through these categories and talk about why they're important to do and some of the data sets that we use in doing these tests. So the first one is clinical decision support. And here we have some examples of MedBullets, HeadQA. These are the question answer ones that test it. And really the idea of clinical decision support, the idea of having these data for clinical decision support is not just testing that specific task. It's also the idea that making sure your system, your model, actually works with clinical NLP very well, because it's a very different sort of text, and there's also a high demand on correctness. It's a very exacting field. The next category, general medical knowledge. So similarly to with clinical decision support, you need to make sure that your model has the information necessary to generate correct context for the either the provider who's using it to perhaps summarize research or the patient who's asking questions. And so the general medical knowledge is, it's sort of like another Q&A based one, but it's tested across different data sets to make sure that your model is actually capable of answering these questions, that it has the information necessary. And if it's lacking that information, there's a couple of remedies. There's obviously fine tuning and all that. There's also augmenting whatever data sources you're using as well. So next one is a very important one, is documentation and patient communication. So it's becoming really popular now for clinical AI agents to be involved in the note taking and the documentation process on the provider side. And what that means is you need to make sure that if someone is going to be using your tool, let's say to record patient notes, to record medication notes, that anything the model is doing, that it actually is doing in the correct way, that it's actually doing the thing intended, because these errors that it may introduce may not be caught until much later, like even after perhaps the patient has already been exposed to the error. And we don't want anything like that. So we want to make sure that the systems that are being built are building this documentation correctly. So another important task is behind the scenes. So this is where doctors are researching particular topics, maybe for a specific patient, maybe for general education, where administration is wanting to examine, what sort of like data is available, as well as looking up what's in patient records. So if your system is allowing this, you need to make sure that it knows how to interact with this kind of data. So PubMed QA is very sort of classic, well-known data set built on the PubMed data. And if you want to interact anything with research, you're going to be interacting with PubMed. And your system will have to know how to read PubMed text and have to be able to form answers and generate quality context from PubMed data. We also have like EHR as SQL, which is tests whether your model knows how to interact with the SQL to access electronic health records. This is very important if, let's say, in sort of an administrative role, if you're looking at population health, or again, to sort of go back to the other example, if you're looking at putting together a clinical trial, to be able to access this information inside health records. And BMT SAS is another one where it's patient notes and it's seeing whether the system can accurately answer questions about the status of patients from these notes regarding a specific disease. So safety and reliability, this is where we get to some of the more classic ones. So there's a hallucination one, there's medical specific hallucinations and general hallucinations. And there is a bit of some fine hairs in between when you're considering hallucinations. What part of it do you need to, will general tests help? What part will domain specific ones help? So hallucinations are when the model is going to be responding overconfidently to something that it doesn't actually know, that it's sort of just making up. And in a scenario in like something domain specific, it can be very confident about something that sounds realistic to someone who's not like an expert in the specific answer. So if you have a patient who's going to ask a question, maybe about an upcoming procedure, or maybe about side effects, hallucinations can be very dangerous. And they also so again, with general hallucinations, you test to make sure, it's not like producing answers that are outside of the bound of the information it's given. But for the clinical medical ones, you want to make sure that it's not tweaking this information by accident. So it's more of a specific thing you want to test to make sure that your model, your system, is giving the correct answers and not answers that might unintentionally misinform the patient. Another one here is a safe child data set. And this is a data set built around a lot of prompts eliciting, trying to elicit undesirable behavior from the model. Both that's like hijacking it to asking it to do, advice on illegal things, or even asking for inappropriate content. Or another thing that will come up a lot in the like mental health context is patients over relying on the model. So patients turning to the model as if it were a therapist. And of course, children are much more susceptible to this sort of a scenario, much more gullible. And you want to make sure that your system, if prompted with some sort of inappropriate behavior, regardless of which one of these is, that gives a proper response. Either warns the person that, it can't do that, that's inappropriate behavior, or it makes sure the person knows it's just an AI. It's not a person, and that they should contact a person, a professional. So another sort of classic concern with models is biases. So a lot of times people will think initially of biases, they'll think of the demographic ones, like, I'll rebias against this group or the other. And those are very important. And those also, they require a lot of testing for robustness, because you can get subtle differences in treatment because there is inherent bias in the data, that is in the way our healthcare system has treated people of different backgrounds. You don't want to perpetuate those problems. So you want to make sure that your system provides not just same, not just is able to provide good context in any sort of specific clinical task. It needs to also be robust against changing the demographic of the patients, because if your model does very well, but it changes behavior and it's not wrong, but behaves differently depending on the demographic of your patient, you could potentially expose yourself to legal risk, but also expose your patient to substandard care. Now, that being said, it also needs to be balanced that there are some protected classes, like, for example, elderly, where there are legitimate different considerations when you do medicine. So when you look at these differences in behavior, you need to test in a domain-specific way. But another important part is also cognitive biases. And these are things that obviously patients, when they ask questions, are going to frame things in a way that makes sense to them, whether that's right or wrong. But doctors are just as susceptible to cognitive biases. And so you want to make sure that your model won't be susceptible to an accidental bias to provide particular answers or particular treatments. So we've actually built a proprietary data set that contains adversarial tests that's essentially trying to elicit these cognitive biases and these biased responses from the model. And then we evaluate what the model does in response to these biased prompts. And as far as for biases, another important one is social biases. This is different than demographic ones. Demographic biases are generally things that, apart from like age and stuff like that, are most of those are going to be kind of irrelevant to the medicine of the matter, except of like certain corner cases. But social biases can strongly affect a lot of things in terms of treatment. So there's like discussion of like how housing is treated. If the model is generating advice and it's completely irrelevant to the patient, you don't. That's another type of bias. That's bias in intended results. So if the person is without housing, or maybe the person is pregnant, you want to make sure that you are responding still correctly in those situations. So again, we've created a proprietary data set using a Lang test to test out these different categories. And again, red teaming is a really big part of this, because the perturbations is one way of testing it. Consider it like it's like a robustness test. Like, oh, we create across these different categories. Are we seeing the same behavior? Are the distributions remaining the same? And that's what we want to see. Red teaming is more pointed. Red teaming is we want to see if we push your system with sort of effectively honey traps, so to speak, of wanting to give the bad answer. Will your system respond correctly? So in our platform, we have we utilize MedHelm, we utilize Lang test, and we have a lot of our own proprietary data sets as well. And even it's possible for you to provide your own custom data sets. If there's a particular functionality you have that's very unique to your system, and maybe we don't support it, you can create a data set that actually tests it, and you can run that on our system as well. And this testing framework, again, needs to be something that's like repeatable and is done to keep your system monitored and make sure it's working well. The other sort of like thing, like, as I wrap up here and get ready to hand over to Alin, an important part, like if you, and maybe some of you are familiar with other regulated domains, but you can't just target the minimum regulation. You have to try and exceed where the regulations are, and test as much as possible. So yeah, I encourage you all, whenever you're building your system or updating your system, just think about testing, metrics. But I think with that, I'll hand it over to my friend Alin.
Okay, thank you, Alex, for the nice introduction. And I will continue next with explaining, let's say, how these things are built together. And what it was, let's say, explained initially, it was how Pacifica evaluates. And now the focus will be how this evaluation actually becomes operational. And let's say this will explain how the difference between running a few tests versus building a repeatable evidence system, as Alex suggested and mentioned several times in the previous section. Can you please go to the next slide, Alex?
Yes.
Okay, so in this one, I want to make one important point that in Pacific Eye, an evaluation scenario is not just a prompt. So it represents a structured test case, and each scenario that it's built has a task that has an input, an expected output, a scoring metric, possible perturbations, and also evidence of how the score was built. So what we what we notice here are like all the operations that happen during the process in order to obtain a real evidence of what has happened in the evaluation phase. And as an example, the task may be a clinical reasoning, documentation, or patient communication, or anything that is related to administration or research. And the input can be patient case, a transcript, medication list, clinical note, everything that is healthcare specific. And one of the expected output in this case is would be can be a diagnosis, a treatment plan, a referral, and so on. So then how we then the process is to define how we score it. So in some cases there is exact match, sometimes it's semantic similarity, rubric, and we also have scenarios in them. It is used LLM as a judge. In special for bias and fairness, we use also parity and stuff for get the perturbed version in some cases. So this structure, it's very important because it makes this test repeatable. So the same scenario that it's configured can be run before release, let's in the gatekeeper part, and then later in the production through the Guardian. So the value that Pacific Eye brings here in the picture is traceability. So we know what was tested, what was changed, when it ran, and in which environment. Yes, so next. Okay, so here now, once we have the scenario structure, we connect it to the right evaluation engine and to the right data. So these are the most important aspects of let's say, of a full scenario that is built. So this is, let's say, important because healthcare AI, it's not only a task, it's a multitude of configuration aspects and scenarios and details that builds that particular task. So a clinical reason task, it's different from a documentation task. And the fairness test, it's also different from a hallucination test. And also in terms of, let's say, a child safety test, it's different than a coding or trial matching test. So Pacific AI tries to combine and come up with multiple sources. So as Alex also mentioned previously, we use research suites like MedHelm and HealthBench for the clinical utility, medical reasoning, and also the physician-built data rubrics that was created. Then Lang test for robustness, fairness, and perturbation testing. And the red team scenarios for adversarial clinical prompts. But we also support dedicated data sets into our platform that can work through the red team tool that it's integrated in the Pacific AI scenarios. So the principle is very simple. So the data set and the metric should match the healthcare task. So that it's how, let's say, we avoid the common mistakes of using one generic benchmark and pretending it tells us whether a deployed healthcare AI system is safe or not. Okay, next. Okay, here we can see the components that are used in Pacific AI and are, let's say, split in 4 major steps. Once we have the scenarios built, so we we can, this is like the end-to-end evaluation flow. So Pacific AI connects evaluation into one lifecycle. So this is the one lifecycle of a given scenario end-to-end. So first is the governor that gives us the inventory, what system exists, what models are used, what risk can apply to the models, and what evidence is available. Then in the second part, we have the gatekeeper that keeps track of what evaluations were run before the release. Let's say this is a pre-production control. If a model, prompt, or RAG pipeline or workflow changes, gatekeeper can run the relevant test suites before the changes goes live. So this is a step that comes between making the product available live to test it first. Then in the third step, we have the guardian, that this is let's say a continuous evaluation in production. So it runs throttle probes with minimal production impact, so we can detect drift, regression, safety, fairness, changes after each deployment. So it's very easy to compare previous version with the current version and run as many versions as the user needs to make sure that the system is safe. And the last one, it's the policy suite that maps the evidence to controls the standards and regulatory expectation, let's say on a quarterly refresh as an example. Okay, the important point here is that these are not four separate activities. They are fully interconnected, so they are dependent one on another to create the end-to-end flow. So the same suite can run before release and after deployment. The same evidence can support engineering decision, governance reviews, compliance reporting, and also model cards that are generating whenever a suite is completed end to end. So Pacific AI gives the organization one evidence chain from inventory to release gate, then to production monitoring, and then to reporting. So these four are one of the important aspects of making a suite and scenario end to end through these environments. Next. Okay, so the success criteria. So we will, let's say, keep a simple flow that I would like to demo after this, that we will start, let's say, with a realistic healthcare use case and run it through the Pacific AI evaluation framework. So the goal is to show end-to-end how a model response can be assessed against a clear rubric, instead of relying on a subjective review or a general benchmark that can be exposed from different providers. This is important for anyone that is using this type of scenarios or evaluation, because it's not only asking, does the model answer correctly? We are trying to, does this AI behavior meet the standard we would expect from a healthcare workflow? So from there, we review the model output, the score, and the rationale that is behind the score. So we are trying, let's say, with by having the LLM as a judge, to decide exactly and to come up with a scoring system that will give a correct analysis based on the data set that was used in the evaluation. So this shows how Pacific AI turns AI behavior into structured evidence that produce in a way clear understanding and how the data and how the system acts. So the demo that will be presenting, it's to show like a full to end-to-end life cycle. It will expose the core building of blocks of the scenarios, then the Pacific AI approach with the scenario, defining the methods, the evaluation categories that can be selected, the 60 plus that Alex mentioned previously in the slides, then evaluation results, evidence that can be listed, and also version comparison of the runs. So the Pacific AI product helps teams move from, let's say, perception-based AI, confidence, to evidence-based AI. So before a healthcare AI system is trusted, we need to see how it behaves in realistic scenarios. So we need to measure it consistently and also use the results to guide in a way the development and to push it to a level that is production ready. So the key takeaway the healthcare AI evaluation cannot be a one-time benchmark. So it has to be a repeatable before release, continuous after deployment, then also connected to policy evidence. So the evidence needs to exist for complete evaluation. So this is the major role of Pacific AI, to make evaluation part of the healthcare AI operating model. And yes, that's on the presentation. I want right now to also have a real demo. I will share screen. Okay, so in this demo, I will show how Pacific AI operationalize somehow the healthcare AI evaluation from the system level. So everything starts from a system. So the important point is that we are not evaluating a model in isolation. So in healthcare, risk belongs to the organization that are deploying the AI into a real workflow, like hospital, payer, provider group, or digital health company. So Pacific AI starts with AI system, then connects that system to LLM endpoints, and in this section we have LLM endpoints that are registered, and that each system that it's used are assigned to a particular LLM. So for this case, for this test scenario that I use in the demo, I have selected almost all the models that we have here in this list, like GPT-5.4, 5.4 Mini, 4.6 Opus, and the Gemini one. And what we can get from this part, it's like also that we will see like the health condition of the model, if it can be used or not from this section. Then another important aspect are the governed data sets that we can identify in the hub sections, where we can upload data sets into a specific format that is dedicated for the red team detection, like having must avoids, and information about data that needs to be tested. And the goal of this one is to create a continuous, let's say, evidence trail to expose what system was tested, which model has powered it, which data sets and suites were used, what the results were, and what that means for clinical fairness, safety, and compliance risk. And I will jump to a real system. So this is a system that we tested as a medical assistant, and we have here all the test suites that I run, and I want to show you one of it. So this one was run against 28 categories. Let me update to show. So we have here a list of groups like that contains multiple categories. So we have here like the three groups: the usefulness and efficacy. Then we have the fairness and equity, and safety and reliability. So these are the three major groups. And then we have like independent subcategories that represents clinical decision support and stuff that Alex presented early. And everything starts from systems. So this is, let's say, the authoritative registry of AI system that the organization is responsible for evaluating and monitoring. So everything starts from here. So each record means represents a real deployed or pre-deployment healthcare workflow. So everything starts from here. So it includes the system's lifecycle stage, like model cards, documents, continuous compliance, and also the status of it. So for this one, the system level view, it's important because the same model can create very different risks depending on how it is used. So clinical assistant, deterioration index, a triage assistant, a scribe, and the prior, let's say, authorization tool all require different evidence. So otherwise, it will be hard. It will be hard to detect stuff if you don't have the evidence from the previous versions. So we began with the system, because the system defines the intent used and the risk and the evaluation coverage. And if we take a look here, 1 second, we can see that we have a leaderboard where we have like all the models that were run against the particular subcategories, and we can see exactly the scores that was given by each independent model. So this show that the evaluation suites assigned to this specific AI system. So in this example, we can see suites for multiple model backends that including like Gemini, Claude, Grok, GPT-5.4, GPT-5.4 Mini, and so on. So the suites are organized around Pacific AI's healthcare evaluation categories, exactly all the categories that were presented, like that 60 plus that exist here. So each of them are under these three main groups that are exposed here, and we see that some of them were run against multiple models. Some of them were only run against reduce amount of models. So if we want to see like how everything has acted against GPT-5.4 and how it acts against GPT-5.4, we have a clear comparison and distinction here. And if we want to go even farther, we can go from the test run and see exactly how this distribution is across all the categories. So we have a clear exposure how the system was tested and how the system was act. In this case, as it was GPT, the LLM was GPT-5.4 Mini, how it act and responded into these categories. So in a way, the system is intended to translate everything into, let's say, an evaluation coverage to represent like a, let's say, medical assistant. If we think as of a medical assistant, we may care about clinical reasoning, treatment planning, patient education, node generation, hallucination detection, bias, and also robustness. So this is what we can identify as a high level. We have this leaderboard where we can check all the scores that we get for different variations. And then another important aspect that we can obtain and check here is, let's say that we have a evaluation on a model, as in this case GPT-5.4 Mini or other models. In this case, we have simple only one version, but for this one, I have two versions. What we can do, it's like we can compare and see exactly how it acts, let's say, for this particular category, that it was like V1 was lower than the V2 in terms of this on the same model, because what I use here, it was like a sample. It was sampled to 10 evaluation scenarios for this demo, and basically whatever scenarios were, some of them were like better than the others. So to have like a clear distinction and clear evaluation, all the scenarios, all the evaluations from the data sets needs to be used to make sure that it gets an accurate score for the evaluation. So all the time after a test suite is completed, to have a clear overview, we have to jump to the leaderboard, and then this leaderboard, it's not a general purpose ranking of models. It compares endpoints against the healthcare specific tasks that selected for this system. So here we are looking at the usefulness and efficacy across models. Then we are also seeing the subcategory results for emergency, for clinical knowledge, for PHI, delegate, patient. So all the HIPAA identification, GDPR. So all the stuff that we have data set for that are registered here. So why this is valuable? Because one model may perform well on medical knowledge, but weaker on treatment and planning. Another may be stronger in summarization, but weaker in clinical reasoning. And for Pacific Eye, the decision is not which model is best overall. The decision is acceptable for the decision is which endpoint is acceptable for the healthcare system to accept, let's say, a risk profile or some risk by taking this evidence from this leaderboard. So that is why the leaderboard, it's tied back to the system and it's assigned to the test suites. Another important aspect that I want to present here, it's the model card that it's built based on the test suite and on the evaluation. So this is where, let's say, Pacific Eye turns evaluation outputs into governance-ready evidence. So basically, after a test suite is run and the evidence looks correct and a review was done by advisor, by someone that it's an advisor. So the model card summarize key metrics across three major areas. So it's exposing all the capability to split all the major groups like usefulness, fairness, and also safety. And this evaluates whether the system provides accurate, relevant, and clinically appropriate outputs across medical and administrative tasks. And then all the scores and everything that was decided to be exposed into the model card are taken from the test results and incorporated and included into the model card. And it is a standard, a CHI standard that it's applied to the medical healthcare world. So the important part is that the model card does not only list scores, it also provides interpretation. So, for example, the system may show strong results. The system may, these are the interpretation. So the system can show strong results in factual, let's say, medical knowledge, but weaker results in complex clinical reasoning or research data analysis. It may perform well on some fairness tests, but show gaps across socioeconomic, housing, insurance, or any other dimensions. It may be robust in some areas and weak in others. So this is exactly the kind of evidence that healthcare organizations need. So not just it passed or failed the benchmark, but a structured view plus evidence that the system is reliable, where it is limited, and where targeted improvement is required. So now, I want, let's say, to close by summarizing the full workflow. So we start from a system. With AI system, we map it to an LLM endpoint, as I expose it here. So an LLM endpoint is mapped to a system. Then we test it using the governed data sets or that are configured in the system by using the test suite that are available through this list, and then we compare the results in the leaderboard to see how the system has acted, and we have let's say a generic model benchmark. So this supports continuous healthcare specific, let's say, evaluation at the level where, let's say, accountability actually sits. So the deployed AI system can be paused, and that gives like clinical, engineering, compliance, and governance teams one connected evidence trail from the system inventory to the model card output that we can see the results on. So thank you all.